So, Sue, I'm going to come to you first. If I could ask you to just share with the group what you've been doing around group clinics and some of your key learnings to date, that would be really helpful.
Yeah, thanks, Georgina, and afternoon, everybody. It's a real pleasure to see you all, or not see you all, in fact, but to be here on just coming up to International Women's Day. So fantastic timing, and looking forward to sharing some kind of experiences of groups, of which I'm a really big fan. So just a little bit of background to my own experience. So I come from City and Hackney. It's a very diverse area in northeast London, and I run the women's health service in the community. And as you know, there's been a massive surge in menopause demand. And so actually taking forward the group model has really been around kind of trying to find ways to meet that demand. So lots of my experience comes from there, although as someone's put in the chat, it is should not be confined just to menopause. I think there's lots of potential with groups, which I can come on to. So I've got around 3 to 4 years experience of this. We've seen more than 4,000 women. And as Georgina alluded to, we have this model of VEE, VGC. And the reason behind that is really, it is a sort of form of triage, or I would like to see it as a form of meeting unmet needs. So we don't just depend on people ad hoc coming into the clinic. We actually go out and proactively invite them. And that gives an opportunity to reach out to people who might not actually get services. And we do find that actually when we look at who comes to services, people have had 2 to 3 GP appointments in the 6 months before they get to see a professional. So people are coming with issues that they may not recognize as menopause. And that's why we like to go out to them, women between 45 and 55, and say, look, if you're interested in this, menopause might be a thing for you. You can come and find out more. And normally we get the groups about this size, to be honest. So this feels a familiar size to me. We have a very good active Q&A. We have a multidisciplinary team. So we have a dietitian, we have a psychologist, and me. We do a little bit of educational stuff, but it's mainly generated by Q&A, and it models the group clinic structure. So we have a facilitator who does sort of shape the kind of the whole session and pull together questions, which I think is really essential, because it is, as you can imagine, trying to manage questions is quite busy and not possible to do at the same time as answering them. So that is a form of it's an access point. And then we invite people. So we've got quite a rhythm going. So we invite a couple of, maybe one PCN if they've never been asked before. And we've seen actually there's a saturation point. So eventually you invite people and people don't want to come anymore, which is fantastic. And so we invite people. So we normally see this number, and from this number, roughly 15 to 20% want to have a more individualized session. So already we've triaged out 80% of people who are just happy to understand a bit more and know what options are available in terms of self-management. And then we bring them in, as Georgina's alluded to the group. So we have this rhythm going on a monthly rolling basis. We have a VE, and then we have 2 or 3 VGCs depending on demand. And it's sort of become quite a norm to us. And there's been a sort of socialization of the process in our place-based partnerships. So people know about it now. So it's sort of, you get a kind of sense of a buzz across an area. And it's become more of an established practice. I'll stop there. I don't know whether there's anything else you wanted me to say at this stage, Georgina.
I think just if you could sort of just encapsulate a little bit of your learning. So what over the last 2 or 3 years, what have you learned? And
Yes.
also do feel free to, because I know you've used this model a bit in other pathways, not just menopause. And I think it's really important, isn't it, that we broaden our thinking beyond menopause now. So just share a little bit
Completely.
about some of the lessons and and also what you've done beyond menopause.
Yeah. Okay. Perfect. So there are some personal lessons. So I would say for those of you who have no experience, it is a case of just, you need the training, but once you've got that, it's quite nerve-wracking to go into, I think, for the first time, but just get on and do it. And you'll become very accomplished very quickly. And the groups run themselves in a sense. You are the sort of clinical person, but there's an awful lot of interaction, and groups are very different in terms of characteristics. It's interesting. but people support each other. There's a lot of learning from other members of the group, and you get more, I guess the more experienced you get, the less you actually have to give, because you can learn what's necessary and what's not. The other thing that you learn is that you get quicker, I think, as Georgina said. You also learn that people know more by the time you get to the end of the group. So if you're seeing 10 people, 8, 9, and 10 will have already learned an awful lot. So you're probably saying to them at the end, what do you want to do? What have you learned? What is your question now? Having heard all the things you've heard. So the appointments are much shorter by the end, but people don't mind because they've already had an hour odd to kind of digest. The other thing I would say is that the timing, you could get quicker and quicker. I tend to lean into the whole event. I tend to always fill an hour and a half. I think that's my style. And I think people sort of expect they're going to be there for an hour and a half, and it varies very little, however many people I have there. So that's another learning point. I think objectively, what have we learned is that people love them. So undoubtedly, universally, we always get people who are very, very positive about them. But more than that, objectively, so we've developed a MenQual score, a sort of abbreviated MenQual, which is the sort of quality of life measure for menopause. And excuse me, you see that people's scores improve over 3 months, regardless of whether they take HRT or not. So it's really interesting that you get an improvement, and presumably just the value of the consultation and some self-care decisions are really helpful. We need to get better at showing system outcomes, and we are trying to build the evidence base, because anecdotally, this and in a modelled way, this is cost effective, works very well. But of course, the impacts are very upstream. If you think about menopause, you're going to uncover unmet need before you start impacting on the system. So you're going to see more people who haven't had what they need before you start reducing down. So don't panic about numbers, but you do have to factor that in. In terms of the other types of services that we might offer, I absolutely think this lends to a whole range of women's health conditions. So I think, first of all, thinking across the whole end-to-end pathway. So we're going population, but you could actually go GP level. So people who come in could be, themselves could be offered a group or an individual consultation. You could then manage people on waiting lists. So waiting well initiatives. There's all sorts of things you could do with waiting lists. Lots of people on Eurogynae wait lists who actually really need pelvic physio and some early preventive intervention. And just a checking in, to be honest, would be really helpful with a multidisciplinary team. And then we've got the long-term condition management. So people who have ongoing pelvic pain, ongoing heavy bleeding, who've been through the diagnostic process, they're still managing symptoms, and they're still trying to learn how to manage symptoms. And then there's a last group, and I think we haven't tapped into this either. So Georgina mentioned about sort of high volume, low complexity care, which is where the kind of biggest bang for the buck is. But I think there are some very special groups there. And I think there's people like women who've had breast cancer, who actually get, a medical menopause post-cancer would be a really good group to tap into. That's just an example. I saw in the chat someone mentioned about PCOS. I absolutely agree. We're just trying to build that. Now, we've done clinics in menstrual problems and PMS, we've done fertility, we've done incontinence, we've done contraception. The only one that didn't work so well was contraception, because inviting people to speak about contraception only brings really people who want natural fertility methods, interestingly. So we're probably tapping into the wrong population, but schools populations might be brilliant for this. So lots and lots of potential here, I think. I'm going to stop now, because otherwise I might take up the whole webinar.
Well, don't worry, Sue. That's what we want you and Kim to do anyway, so it's not a problem. There are a couple of questions, but I'm going to hang on to the questions until Kim's done her first little intro as well. But also, something that occurred to me when we were sort of thinking this through was is also infertility. I don't know if you mentioned infertility, but I think that's a really potentially powerful one as well, isn't it? Because, you know, there's also a lot of issues around limited access and that kind of thing. And, you know, so it's really powerful. So Kim, over to you to share your experience. So Kim's coming from a slightly different angle as a commissioning lead in Devon.
Yes, hi everybody. It's lovely to be here and be able to talk about our women's health journey with group clinics in Devon. I'm hoping to have some of my amazing women's health physio colleagues on the call. I do hope that they've been able to join. But in terms of our work with group clinics, so I would say we're very much on the journey at the moment. So I should probably give a bit of a background. So I am the specialty improvement lead for Devon for gynaecology as a whole. And one of the issues that we know is a national issue, and something that Sue also mentioned, is urogynecology as a subspecialty. And what we try to do is with a whole group of gynecologists, urogynecologists, nurses, the women's health physios, is talk about where the pressure points are. And think about how we might be able to deliver care differently to tackle the quite significant waiting lists for patients with urogynecology issues. So with our task and finish group with the pelvic health physiotherapy leads, we have talked about what we might be able to do for women at the very front end of the pathway in terms of ensuring that women can actually wait well and maximize their pelvic health before they get to their very first physiotherapy appointment. So the opportunity we've talked about is once a woman is added to a physiotherapy waiting list, can they have a group clinic or a webinar type forum to join where the physiotherapists lead that session with really good advice on pelvic floor exercises, doing that Q&A scenario where they're answering direct questions from women about their pelvic floor health. And then when their waiting time is unfortunately quite long, they are in the meantime taking all those actions that can help maximize their pelvic floor health and hopefully not deteriorate whilst they're on that waiting list. Another opportunity that we're looking at is a pre-appointment group session, which will enable women to access some of the information that they would want to seek at their first outpatient appointment. So dealing with some of those frequently asked questions that can take up a significant amount of appointment time, but could be all dealt with and addressed ahead of that appointment happening. And some of that might be, you know, just outing some of those fears about the appointment, what's going to happen at the appointment, what to expect, what isn't going to happen, and just ensure that there's a maximizing of attendance rates, and hopefully doing a bit of capacity release for the teams to do a little bit extra, be that admin or potentially seeing additional patients. So I would say it's a really exciting journey. And I think my learning, if I may say, Georgina, is really about this is a lot to do with excellent clinical engagement, and actually not just clinical engagement, whole team engagement. So you need your consultants, your nurses, your managers, your admin team, all ready and enthusiastic and with the skills to deliver group clinics. And with that, I think we've found that you can't just have that. You need a problem that needs solving as well. So it can be you've got a really engaged clinical team, and that can run off its own steam. But the other thing is having a look at where your problems are. What are your waiting list issues? What are your follow-up? What's your follow-up activity looking like? How can you drive that down? How can you deliver that much more efficiently? And seek to offer up a group clinic setting as a means to deliver more productive care. That's probably it for me for now.
Yeah, no, and I think linked to that, Kim, I think one of the things we've been working very closely together on that engagement piece, haven't we? And I think data is really important, isn't it? You know, having that, if you like, diagnosing where in the system is the bottleneck. Actually,
Yes.
the other thing that I've learned personally, working very closely with you and your teams, is not staff engagement is key, and staff engagement happens when you involve the staff in the design of the group clinic, particularly the clinicians. They have to feel as if it's theirs and they own it and that they designed it.
Absolutely.
So we can't, much as it's wonderful to have kind of like template things, and we have lots of templates in our toolkit, for instance, of tried and tested group clinic models, but what we always say to teams is take the template and adapt it for your own service. So, you know, I'm just thinking of you know, how we've done some quite careful kind of unpicking with some of the teams that we've worked with, not just in gynae, around, you know, what is it that happens in this appointment? How, you know, what are the things that you're trying to achieve? And which ones of those are the bits where there's more repetition? And how could separating those out or doing that a different way really help you? So there's some really it certainly compared to general practice, working in specialist services, that's a really key thing. I think is it's different in every service is the other thing, isn't it? Some people do it one way, some people do it another way. So you have to sort of have that diagnostic element of the design of this. We call it co-design in our training. Actually, it's about co-designing the group clinic model with the people who are going to deliver it, and ideally because the co-design with patients happens in the group clinic when they get the chance to pose their questions. So let's just pick up on a couple of the questions that have come into the chat, and then we'll move on to thinking about how can we harness this. You know, how can we, what are the runners and riders? And it would be really interesting if those of you who are interacting with the chat would maybe share with us some of the things based on what you've heard from Sue and Kim so far. What excites you? What are the models that excite you about this? And let's see if we can pick up on those. So I guess both of you, we could answer this question. What is the downside of group clinics? You know, we want to give a balanced view here. So Sue, let me start with you on that. Any thoughts on the downside?
So I suppose that we have to be honest about the limitations of them. You know, I mean, I think they're a great model for some people and some situations. And I think being upfront about that is really important. So I see someone's put in the chat about what do you do if there's a language barrier, for example. Now, of course, if someone doesn't speak English, they're not going to be able to come to a group consultation. So I think recognizing that it widens inequalities in one way. The way it equalizes is by, well, in our model, it invites everybody in. So it probably reaches out to a more disadvantaged population, but it does exclude some groups. So it excludes people who don't want to come to a group. That's fine. You have to offer an alternative, which is, you know, feels as good, doesn't disadvantage them. And it's going to exclude, there's going to be digital exclusion and there's going to be language barriers. I think that if it's planned hand in hand with a face-to-face group model, then it's better. because you can do so. For example, we did some work with, we've got a very big Turkish community locally. We did a group with a Turkish advocate and a group of Turkish women, and that was very effective, but it was very different, and it ran in a very different way. So I think flexibility is really important. What else? People, I think, are often anxious about groups because they think, you know, oh gosh, what have I got to share? Is it going to be confidential? So you have to be very upfront about the confidentiality, and also that people must understand that they are sharing personal information. And if they don't want that, and we would normally say at the outset, if this isn't for you, if you thought it was for you and then you find it's not for you, just leave. That's fine. And then I think the last caveat is what happens in the dynamic of the group. So usually that's extremely positive. Two things that I've found, and they're really rare. One is someone that's a little bit disruptive. So we had someone come in, for example, who was very anti any form of sort of medicalization, which I completely understand, but became a little bit sort of disruptive of the rest of the group who might have been more interested in talking about things like HRT. So that was tricky to manage, but not insurmountable. And then the other thing, which I don't think is a negative, but it can feel it, especially to begin with, people sometimes get terribly upset, and then you have to manage the group. And normally the group manages itself, to be honest, and they're much more supportive than you can be on your own. But it's just sort of not shying away from that and just finding a way. And it's unusual for us, isn't it? I can manage one-to-one upset very easily. Managing it as a group online, I've got much better at. So those things I think are very frightening when you start off, but actually I find them, you know, they're very rewarding, incredibly rewarding, because people, if you get it right, people feel held, I think. So, you know, they're all going to be, you'll, I think, experience different challenges from the ones that we've experienced, but those are the main ones that come to mind.
That's really helpful, Sue. And I think the issue around sort of digital inclusion and making sure that you've got alternatives that are face to face is really important. And there's a report just come out from NHS England, which we can actually make a little car part to perhaps send to everybody today. And that is a big thing that comes out in the report, isn't it, around the value of group clinics in delivering the 10-year plan, and how it is important to make sure that you have face-to-face alternatives available, but that can be face-to-face groups, you know. The other thing on the digital side is to just remember that sometimes people need a little bit of a nudge to actually engage with digital, and digital is so important in our world these days that if we don't encourage people who maybe are a little bit shy to give it a go, you know, they can get left behind. And that's another type of inequality, because they're excluded from things in life because they're not so confident about digital. And so the other thing about the group clinic model is it can help to give people a bit of a motivation to give it a go, and then often it's easier than they expect. And I think your VEE, yeah, I was going to say your VEE model is a kind of easy way in, isn't it? You know, it gives people a little taster.
I was just going to say that, because what it does is it actually models the group. So it's the same format. So people who might have felt a bit kind of uncomfortable in the big engagement event, or might have just posted in the chat, then sort of know what they're going to expect when they come to the group. So it's a very positive choice.
Yeah, I love that about your model, actually. I really do. So, Kim, from a sort of commissioning point of view, there's a downside a little bit to group clinics as well, isn't there? We were talking about it just the other day, thinking about, you know, how things get measured in the system right now is a little bit of a barrier, isn't it?
It is, and yes, it is, and that's about how an attendance is actually recorded, and if a patient attends a group clinic, does that count as an appointment or an episode of care? And some of that needs to be really teased out and understood from an activity planning and financial and contractual perspective. So yes, I think there are things that we definitely still need to work through. And from my experience, I know we've talked about group clinics from a health inequalities perspective, but if I think about the outpatient transformation work that I've done previously, when there was the shift from face-to-face appointments to remote outpatient appointments, if the technology didn't work the first time, you've lost the patient right at the first hurdle. So I think one of the things I would say is we've got to be really, really confident that the technology is all going to be working for a webinar or a virtual group clinic. And make sure everything works like clockwork. You can't guarantee it, but if we give a patient or a person a good first experience of an online group session, then that confidence will be built and we won't lose them from the technology access forever.
I think that's a really good point. And it's really nice, I think, for people to understand and know that you can use Microsoft Teams. You know, you don't need some fancy platform to do this. You know, I think that's really reassuring. And a lot of people out there, you know, they use Microsoft Teams at work and things. So they, you know, not everybody, but, you know, a lot of people have got some familiarity with that. So let's have a little think. So you've talked about Eurogynae, Kim, as being your kind of baby that you want to really see moving forward. What everybody post in the chat if you've got ideas. Sue, what are your kind of plans? What are your ideas about, you know, you're the our amazing national clinical director for women's health. So, you know, in an ideal world where, you know, the group clinics are working to their most kind of impactful and the engagement event model has been adopted widely, what would you see as being the key things where this model would be making a big difference to waiting lists?
Yeah, so first thing to say is I'd like to see it as a key sort of one of the elements of largely neighbourhood care for women's health. So I think that, you know, you've got your GP services, you've got hopefully your intermediate services, women's health hubs, if you've got one. You've got your intermediate level, which is the groups, and then you've got your specialist services and hopefully a sort of single point of access. So in this, you know, the dream would be all the things that involve women sitting at home with unmet need, we would address by inviting them and doing groups. So on my list is incontinence. We ran a virtual engagement event for incontinence. It was booked up within 5 seconds. So lots of people sitting at home who are too embarrassed to go and get help. So that kind of thing. People who don't go out because their periods are too awful to leave the house, who think I can't go to the doctor because it's a normal thing. We've talked about menopause. So those very basic things people are worrying about. Then thinking about what do people actually go to the GP with when we're moving a bit more to a sort of less population-based thing, more kind of disease-oriented. Someone's mentioned PCOS. That is my absolute... I kind of worry that we're not doing very well for people with PCOS. There's a prevention opportunity there. There's a multidisciplinary care opportunity. They're obviously a smaller population. You have to go looking for them. That's going to be challenging. But I think that's a sort of key kind of general practice population. I would like to do some waiting list management. So, Kim, you know, you mentioned, I think Eurogynae is absolutely on its knees. And I love the idea about preparation. So how can we bring people into groups who are, you know, hysteroscopy, who are on a waiting list for hysteroscopy, who really don't know actually what to expect? You know, can we just inform people better? And then some of them will go, no, thanks. Or some of them go, I'm on the wrong list here. Actually, I don't want this kind of procedure. So I think we can get better at that. And then I think, you know, I think we could have some non-medical elements of the multidisciplinary team. So I think, for example, people with endometriosis who are trying to manage pain in the community, we could have some pain management specialists alongside psychology who might support people who are just having to live with difficult situations. And that's before I've even started in maternity and antenatal and postnatal. So I think lots and lots of opportunities.
I actually think that this idea of using the group clinic before appointments is really powerful. Actually, I think this is a new idea that's come out of, influenced, I'll be honest, Sue, by what you've been doing, and then some of the discussions that I've been having with Kim about what's going on in Devon. And I just think there's something in that, particularly where it's something quite intimate going to happen at the appointment, and people might be feeling worried, embarrassed, sort of really anxious about it. If it does nothing but actually mean that they feel less anxious when they go to the appointment, I think that's quite important. Something that's some of the things that have been also posted in the chat, which we have got quite a lot of primary care people in the meeting today, is people who are not attending for cervical smears or breast cancer screening. Imagine a VEE where they could come along and you could talk about what happens at a smear, as a smear, why it's so important. You could maybe run that in different languages. It would be really powerful, wouldn't it, Stu?
Yeah, so I think this is interesting because I absolutely agree. We haven't had huge success in inviting people for preventive interventions. So I think some of this is about weaving that in to something that gives people the thing that they want. So in the menopause, it's a really good opportunity to say you're up to date with your mammograms and your smears, and do a bit of a talk on that. But I think the learning from the contraception event was that this is a kind of, do I really want to go to a group for this sort of extra kind of prevention? And you get the sort of worried, well, the people are always going to go for their prevention interventions anyway. So I think it has to be an opportunistic thing on top of offering something else. But I might be wrong, but I think it's a good opportunity. It's just how to get people to come.
Yeah, and remember, we're not only talking about virtual groups here. So you could do something around smears, as an outreach thing in the community with a group of people where you've got very low uptake. They did try that in Birmingham, actually, with more of a sort of engagement event rather than a group clinic, and they did it for menopause and also smears with Southeast Asian community, and where there isn't even a word, I think, for menopause in the language. And they generated lots of people wanting to come for appointments, which they then did as group clinics afterwards. So there's, again, similar kind of thinking around that. The other one is, because I know it's a big issue with a lot of women's health hubs, is Mirena fitting, or implant contraception to support shared decision making as well. So there's something magical that happens in a group around decision making. So, Kim, apart from the Eurogani work, which is going to succeed in Devon for sure, over the next few months, and which is hopefully going to give a really nice case study to share with the rest of the country who are also struggling, any other things top of your list of what you'd like to see happen?
Well, I think top of my list would be seeing group clinics implemented in any service where they can be valuable. I think this needs to be part of our mainstream delivery of care. And yes, we will need to work with certain services to kind of build a greater evidence base, and provide that ongoing enthusiasm and faith, and generate the buzz around group clinics. But I really do think if we are going to motor towards elective recovery and drive down our waiting lists, we all need to think differently about how we are actually delivering care day to day. So in all of our specialty improvement work in Devon, we will be asking the question of our service leads and our clinicians is, where will a group clinic work for this issue? So yeah, I'm thinking big scale stuff.
Yeah, and I think that so the final question that we had on our little list, and I am very aware of time because we've only got about 8 minutes left, and I know Alicia will be keeping an eye on us if I don't keep an eye on the time as well. But you know, we're very lucky, Sue, because Kim has been involved in the One Devon project, which is a piece of work looking at how do we mainstream group clinics in an ICB, and she's up to speed with it. She knows all about it. She's like, you know, she's as she said, she's going to be asking everyone, where's the group clinic model in your pathway, or where could it be? But how about we haven't got a Kim in any other ICB, actually, quite honestly. What can we do to make sure that this does get thought of? What are your thoughts, Sue, on that?
Oh, you're asking me. Sorry.
Yeah,
I'm
yeah.
focusing on the chat. Yeah, I mean, I think it is making the arguments at all level of the system, you know, and unfortunately, right at the moment, the arguments to be made are around waiting lists. So I think we can hook it on waiting lists. Our evidence base needs to be better. We need to have a national drive, which, Georgina, I know you and I are trying to be involved in, but we need to diffuse it down. So people like Kim at ICB level, but also at the regional level. So really dripping this down the whole system and measuring the right things. So I think, unfortunately, and I think, Kim, you raised this as well, at the moment, the focus of what we measure is in secondary care, and the impact of this is further upstream. And, you know, we're actually trying, you know, the government wants to do, you know, secondary to primary shifts, treatment to prevention shifts, but we don't have the metrics that can demonstrate how that impacts. And unfortunately, that's quite a slow time, you know, it's a long time scale for that to thread into waiting lists. So I think there are some quick wins that we have to focus on. Where are the pinch points on the waiting list and with people coming in like menopause? I mean, menopause is a quick win because of all the bleeding and the amount of time that is taken up in the secondary care services. But it all at the moment focuses on trying to take pressure off secondary care. So we need to be able to demonstrate that. Evidence, metrics, and the economic arguments, I think, are the three main points, and leadership for.
Yeah, absolutely. And don't underestimate leadership is what I would say to you both from my experience. It's people like you who will make this happen, you know, for sure. Because there is a lot of skeptical clinicians out there who cannot believe that this is possible, and we have to, it's your leadership that will kind of persuade them. So we are getting towards the end of the session. There are a few questions in the chat which we haven't managed to answer. So what we will do, because I think we can answer almost all of them, because they're quite process orientated, is that we will send a quick Q&A in the follow-up email to pick up on the 4 or 5 questions that we haven't managed to answer. And I'm going to hand back to Alicia to just bring the session to